Thank you for joining. And today, like we discussed, we are going to discuss the nuances of hypothyroidism management. So this is the talk for today. So these are the things we'll be discussing today. We'll discuss the definitions and explanations of terminologies with regards to hypothyroidism. We'll discuss the nuances of overt hypothyroidism management. We'll discuss what is overt hypothyroidism and we'll discuss how you manage those. We'll discuss nuances of subclinical hypothyroidism management. And finally, we'll end with something called refractory hypothyroidism. So these are patients which are a little difficult to manage. So these are the things we'll be discussing. So we have a lot on the plate today. So let me just dig into the topic. What we'll not be discussing, hypothyroidism in pregnancy because it's a separate and a complex topic in its own. We'll not be discussing female infertility. That's again a separate topic in itself. And we'll not be discussing pediatric or congenital hypothyroidism management. If anybody is interested, we can have future talks on all these three topics. But they are not the features of today's topic mainly. Our topic will be routine hypothyroidism cases. And there are a lot of other nuances to that also. That is what will be. So let's start with the definitions with regards to hypothyroidism. So that is what we'll be talking in the first part of it. So what is overt hypothyroidism and what is subclinical hypothyroidism? Now you would have seen a lot of people use these terminologies very frequently. So overt hypothyroidism. So let me start with this. We all know the feedback mechanism of thyroid, right? So we know that you have the thyroid TRH, which is released by the hypothalamus, which acts on the pituitary, which releases TSH. TSH acts on the thyroid gland to release T4 and T3. And remember, T4 is a pro-hormone. So this is something which is important. We all understand this. And T4 gets converted to T3. T3 is the one which acts on the tissue. So T3 is what acts on the tissue receptors. And then T3 also gives a negative feedback to TSH, also gives a negative feedback to TRH. Okay, so this is the axis which we all learned in physiology, but kind of reinforcing this as an important point here. So this is how thyroid function really happens. So remember, T4, what we generally prescribe is a pro-hormone. So that is what ultimately then acts on the T3. Again, just reminder, we'll not be discussing virtues of T3 management. Right? A lot of people would have questions on T3, but we'll discuss that as a separate topic because a lot of nuances there as well. So we'll not be discussing in detail of T3 today. We'll be focusing our treatment on the aspects of T4 mainly. I'll give you a brief things about T3 here and there, but we'll be mainly discussing T4, which we are using as a normal, treatment option in most of our patients. So this is what typically happens in, a thyroid axis. Now, the interesting thing is, again, a very important nuance point here is that T3, I told you, acts on the various receptors, and there are various receptors. And then there are various end organ action of the receptors. So when T3 acts on the liver, it increases the production of sex hormone binding globulin, SHBG. When T3 acts on the cardiac tissue, so they can use this as tissue biomarkers, right? You can use this various tests as tissue biomarkers. Okay. So when T3 acts on the heart, it increases increases the production of NT-proBNP. When it acts on the vascular tissue, or you can say when it acts on, it actually reduces atherosclerosis. So it reduces the atherosclerotic deposits, and in fact, it reduces LDL level. So an important point here is, and we'll be discussing this in a little bit more detail in the, next few slides. But remember, hypothyroid patients, they tend to have uncontrolled hypothyroidism. We tend to have an increased LDL. Right. So this is something which we need to understand, and we are seeing a lot of these patients also. So when you see a patient in clinical practice with uncontrolled hypothyroidism, we need to understand that uncontrolled hypothyroidism increases the LDL levels. And often correcting the hypothyroidism corrects the LDL level. So that is also something. So it's always a good idea to reassess the patient's lipid profile after the thyroid function has been corrected, especially in patients with overt hypothyroidism. hypothyroidism. Now coming to what is overt and what is subclinical. So when you have increased TSH but with normal T3 and normal T4, this is known as subclinical hypothyroidism. Okay, this is the definition of subclinical hypothyroidism. Now in these cases, generally the TSH is generally less than 20. Okay, in most of these cases TSH is less than 20. So this is typically subclinical hypothyroidism. And when you have elevated TSH with low T3 and low T4, this is overt hypothyroidism. Now, what you need to understand is that the best test to detect, so the most sensitive test for detection of primary hypothyroid disorder is TSH. This is because when the TSH is, TSH elevation is often logarithmic. So we talked about the, the feedback mechanism over here. Now, even a mild reduction of T3 and T4, if there is even a mild reduction, there is increase of TSH in logarithmic proportions, right? So that it multiplies, amplifies in value, right? So even a mild reduction of T3 and T4 will lead to amplified increase of the TSH, which is why you find TSH as the most sensitive test for detection of hypothyroidism, right? So that's why we generally use TSH as a screening test for hypothyroidism in most situations, except in one situation which we'll discuss in the next slide. So these are the concepts of subclinical and overt hypothyroidism. Okay. Now let's talk about what is primary hypothyroidism and what is secondary or central hypothyroidism. Now this is a very important nuance which I think all clinicians, all physicians need to understand this. This is an important area, and this is again what is not often there in your textbooks. It's not. I don't think it's explicitly mentioned in Harrison. It is there somewhere in between the lines, but it's not explicitly mentioned here. So this is an important nuance point, right? Now, like I told you, the pituitary gland, right, produces TSH, which acts on the thyroid gland, right, which acts on the thyroid gland to produce T3 and T4, right? So we know this mechanism. Okay. Now, if somebody has undergone a pituitary surgery or has a pituitary tumor or pituitary adenoma, in that case, the TSH production should reduce, right? And hence the T3, T4 production is also reduced, right? Now, what is primary hypothyroidism? Primary hypothyroidism is when you have the disease of the thyroid gland and not of the pituitary, right? So the thyroid gland is affected, and because of that, the T3 and T4 are reduced, but TSH is increased, right? So this is primary hypothyroidism. So again, primary hypothyroidism is when you have elevated TSH with low T3 and low T4. In some cases, like we saw, subclinical cases, there will be normal T3 and T4. Okay, so this is primary hypothyroidism. Then what is secondary hypothyroidism? So secondary hypothyroidism is when you have, okay, so secondary hypothyroidism is when you have the pituitary gland which is affected, right? So the pituitary gland is affected, hence the TSH is not produced by pituitary gland, and hence downstream the T3 and T4 are also not produced, right? So in that scenario, the obvious clinical presentation would be that the TSH would be low and the T3 and T4 will be low, right? So TSH is low and T3 and T4 are also low. But in reality, it is not so. In cases of, so this is typical, this is a classical central or secondary hypothyroidism. But in real life scenario, this often does not happen. In real life scenario, central hypothyroidism, how does it look like? You will have low T3 and low T4, right? And when I say T3, T4, I'm, you could also equate that to free T3 and free T4. So I'm not separating those two. So you'll have low T3 and low T4, but the TSH can be low, can be normal, or sometimes even high. Okay. So this is the trick part in central hypothyroidism. Now, the reason for that is TSH tends to have a higher half-life, tends to stay in the circulation, sometimes even aggregates with certain antibodies, and hence stays for a longer time in the circulation. Because it stays for a longer time in circulation, even in patients with pituitary, with central hypothyroidism, sometimes the TSH level can be high. In some cases, it can be often normal. In some cases, it can be low. So if you find a situation where T3 and T4 are low, but TSH is low or normal, it is, in both these cases, you should consider central hypothyroidism. This is obvious. So you will ask me, how will you differentiate whether, now I told you that TSH in central hypothyroidism can be low, can be normal, or can be high. So you will ask me that if TSH can be high, how will you differentiate this from primary hypothyroidism? Remember, primary hypothyroidism also T3, T4 will be low and TSH will be high. Now the answer to that is the TSH value, right? The answer is TSH value. So if you have a patient with low T3 and low T4 and TSH is generally, in this, some cases that people use different cutoffs, but generally if the TSH is less than 20, definitely if the TSH is less than 10. So let's say TSH is 8, for example, right? TSH is 8 and T3 and T4 are low. In this case, you should strongly suspect, right? So again, let me paste this. If the TSH is, let's say, less than 10 and T3 and T4 are low, you should strongly suspect central hypothyroidism and not primary hypothyroidism. Now, why this is so is because for the TSH to really, up till a TSH of 20, the body has a capacity of increasing the T3, T4 production. So if you have a primary thyroid disorder, in that situation, up till TSH of, generally up till TSH of 20, body has good reserve. So the body keeps increasing the TSH and keeps increasing the T3, T4 production. So if you have a primary disorder, up till a TSH of 20, T3, T4 will often be normal and not low. So I hope this point is got across, right? And in some cases, like I said, TSH up till 20 can still be central hypothyroidism. So if you have a patient with T3 and T4 which are low, but TSH is, let's say, 16, this case also you should suspect possibility of central hypothyroidism, right? So this is a very important nuance which you need to understand, right? Now it completely changes the game. Thyroid disorder because of pituitary or thyroid disorder because of primary thyroid gland is completely different picture, right? So I think this difference is very clear. If you don't understand this difference here, please hold me back to ask me this. If you have any queries regarding this, please ask me this, because we can, so if this point is clear, we can move ahead, right? Hope this is clear to all. You can, I think, unmute yourself. I have not allowed unmuting. Just a second. Yeah, if you have any questions regarding this, can we move ahead?
You can unmute yourself temporarily, ask the questions, or we'll go ahead.
Yeah. So I think Neeraj has asked. So the point I'm trying to make is that, see what happens, primary versus central, right? This is a very important. In fact, this is the take-home message. I have a very important take-home message for today. So if you have a primary thyroid-related disorder, up till, what the body does, like I told you, the pituitary gland keeps increasing the TSH to increase the T3 and T4 production. So up till a TSH of 20, the body has the full capacity of increasing. So in a primary thyroid disorder, if up till a TSH of 20, T3, T4 will often be normal. But if you find T3, T4 to be low, think of a central hypothyroidism. This is an important point which I'm trying to kind of push through. So if this is clear, I think we can move on to the next area, right? So if you still don't understand, we'll get back to this point again at a later stage. Okay. So let's then move ahead to the further nuances, right? So this is a very important nuance point which I wanted to really put across. Okay. Let's then move ahead to the next concept, right? How will you manage the nuances of managing a overt hypothyroidism, right? So like I already discussed, what's an overt hypothyroidism? Overt hypothyroidism is when you have TSH which is elevated and often more than 20, right? The T3 and T4 are low, right? So this is a overt hypothyroidism. These are your classical hypothyroidism patients which you see in clinical practice. These are not your mild hypothyroidism. These are classical hypothyroidism patients, right? So a few nuanced things we should consider. Now, first frequently asked question is in this situation is, should you start this patient on full therapeutic dose or should you do a gradual dose titration, right? So this is an important or commonly asked question. So, let's say a patient comes to you. Let me give you a case here. Let's say a patient comes to you with TSH of 100, right? TSH of, let's say, 100 TSH. T3 and T4 are low. Okay. So what would you do in this situation? Would you start this patient on levothyroxine? Remember, we treat this patient with levothyroxine. So you start this patient directly on levothyroxine of, let's say, 100 microgram, or would you start this patient on 25 microgram and then gradually increase the dose? Okay. So the answer to this is, right, there was a study which was done by Roos et al. Right? In fact, this is the seminal paper on this, where they compared in patients with overt hypothyroidism, they compared full therapeutic dose, and full therapeutic dose is defined as 1.6 to 1.7 microgram per kg. Right? So they compared this 1.6 versus started on 25 microgram and gradually up titrated every 4 weeks. Right? So that is what they did. And at 24 weeks, they found that improvement of symptoms was similar in both the groups and safety was also similar in both the groups. So their conclusion from this paper was that instead of waiting and gradually increasing the dose of levothyroxine from 25 every 4 weeks, you can directly start the patient on full therapeutic dose of 1.6 microgram per kg because the safety is similar. So why, call the patient every 4 weeks and keep increasing the dose? Instead of that, you can directly start the patient on a full therapeutic dose of 1.6 microgram per kg, right? So this is a theory, but of course, you can start with a lower dose and gradually up titrate. You can do either of the situation. The clinical result in both the situation is same, right? So you'll have same. So either you can start the patient on a lower dose and gradually increase, but we know that in our clinical practice, often we will have patients lost to follow, right? So if you have patients, where your likelihood of loss to follow, you can directly start the patient on full therapeutic dose of 1.6 to 1.7 microgram per kg, right? So this is the full therapeutic dose. So the ideal dose to give in a patient with overt hypothyroidism is directly a full therapeutic dose. So if a patient has, let's say, patient is 50 kgs, right? Typically, I would say a 50 kg person, if you multiply it, the value will come to around 75 micrograms. So you can start the patient directly on 75 microgram of levothyroxine. For other, weight, you can calculate. So weight-based dosing is an ideal way of treating the patient with overt hypothyroidism. Now, again, there's another study where they looked at the various doses depending on the etiology. In patients post-radioactive iodine therapy for thyrotoxicosis of Graves' disease, typically the dose requirement is 1.5 microgram per kg. In autoimmune, that is Hashimoto's, that is most of the cases that we see, have 1.6 to 1.7 microgram. And athyrotic, so that is patients who have undergone thyroid surgery, total thyroidectomy, in this case is 1.8 to 2 microgram per kg is the typical dose that you require. So you can start this patient on directly on these doses depending on the, right? So 1.5, 1.7 and 2, right? Or 1.8 to 2. So post radioactive iodine, you can start this dose. Most of the typical cases, autoimmune cases, you start 1.6, and athyrotic cases, you can start patient on 1.8 to 2 microgram per kg. Okay. Then, of course, when should you recheck the TSH. So let's say a patient comes to us with overt hypothyroidism. Again, let's get back to the case. So patient comes to you with TSH of 100, T3, T4 are low, right? So we directly decided to start the patient. Yes, sir.
Sorry to interrupt.
Yes,
Couple
sir.
of questions can be taken just now,
Yes, sir.
especially
Yes, sir.
from
Yes.
GP.
Yes, sir. Absolutely. Okay. So let me see the questions.
I'll tell you. The
Yes, sir.
questions are in elderly patient, in patients with CAD, do we start with these doses only?
Yes, sir. So good question, sir. I'll start with, I'll address this question right away. So I think this is a very important question, right? So, well, I was going to come to that. So, and that's a very important nuance. So let's take this point here itself, right? So older patient, right? Older patient or patients with coronary artery disease or patients with a history of atrial fibrillation or history of any kind of, arrhythmia, either supraventricular or ventricular arrhythmias. In those all these cases, it's always better to start with a gentler dose of 25 microgram, right? 25 to 50 microgram, even in overt hypothyroidism, and then you can gradually up titrate the dose, right? So, well, I was coming to that point at a later, but I think this is a point well taken. So, older patient, because what can happen is sometimes giving full therapeutic doses in elderly patient, you can in fact precipitate a ischemic event, right? And you can in fact sometimes even trigger a arrhythmia, right? So this is something you have to be a little careful. So in older patients, patients with known case of coronary artery disease, especially ischemic coronary artery disease, patients with atrial fibrillation, patients with tachycardia, right, or arrhythmias, you could consider starting a lower dose. And like I said, in this study, in either case, either you start with 25 microgram and gradually up titrate, or you start with full therapeutic dose. The symptoms are similar. So in older patients, you can then consider being a little bit more careful and starting with a lower dose and gradually up titrating. Right? So I hope that answers the question. Okay. Any more questions? Ma'am, you can, if you have a question, you can unmute yourself and you can ask. There's no problem. Right? No issue of interrupting me anywhere. Right? You can interrupt me. You can ask me a question. I think we are trying to kind of have an open discussion. So please feel free to ask. Okay.
Couple
Yes,
of
sir.
queries that are always there in patients' mind is TSH 100 is serious disease, TSH 50 is less serious, and TSH 22 is not.
Right, sir. So which is completely incorrect, because what you're looking at when you're looking at a TSH is you're looking at the body's capacity to compensate for the thyroid disorder. In fact, like I would say, patients we discuss central hypothyroidism, right? I have seen, so often I've seen, especially pituitary disorders, TSH often tends to be somewhere around 8 or 9, and T3, T4 tends to be low, right? In this type of picture, you can see serious conditions like bradycardia. In fact, you can see typical, the ECG changes which are textbook prescribed, textbook mentioned ECG changes of hypothyroidism. These type of pictures you'll typically see in patients with even with a lower TSH, but the T3, T4 are low. So actually, the symptoms and the seriousness of the disease, right, depends on multiple factors. So seriousness of a thyroid disorder would often depend, it will not depend on TSH. In fact, it will depend on the T3 and T4. Secondly, it will depend on the impact of the thyroid disorder and the duration of the disease. So what happens is in autoimmune diseases, if you have a longer duration of disease, often what happens is that the body compensates for that. Whereas if you have a more recent development of disorder, the disease tends to be more severe. Again, disease tends to be more symptomatic. So if a patient undergoes a total thyroidectomy, right, the patient tends to be more symptomatic because the patient did not have the time for compensating. The body did not have time for compensating for the thyroid disorder, and often the TSH would obviously be high, but at the same time patient will be more symptomatic compared to a patient who is having the disease for a longer duration of time. So the seriousness of a disorder would often depend upon the multiple factors rather than just on the TSH value. So I think it will be wrong to kind of judge the patient based on the TSH alone. You should look at all the clinical scenario. Also, a very important nuance which you need to understand is that A lot of these patients, especially again, sometimes long-standing thyroid dysfunction, you can also have, you can have some cardiac abnormalities. So some of these cases, you can, you can have features of heart failure with reduced ejection fraction. So in fact, a very important cause of heart failure is overt hypothyroidism, right? So important and potentially treatable cause of heart failure. So again, a long-standing thyroid disorder, you can often find overt hypothyroidism patients, you can often find heart failure. A lot of these patients, in fact, if you give them levothyroxine, the cardiac function often improves. So you can visibly improvement of ejection fraction in echocardiography, you can see in some of these patients. So again, the cardiac compensation also is a very important determining factor of the seriousness of the disorder. And also, some of these patients can have serious pericardial abnormalities, sometimes even cardiac tamponade, right? So these are again something which you can see in some of these patients if you look carefully. So pericardial effusions, cardiac tamponade can also happen with overt hypothyroid patients, right? So this is something you should be careful. Right? Okay, so I think any more questions, sir? We can move on.
We can go ahead.
Okay, so then again, important frequently asked question and also frequently missed problem, again from both the doctors and patients perspective, is how frequently should you check your TSH after changing the levothyroxine dose, right? So we have some, we have both types of patients. We have some patients who have never checked the thyroid again after starting their levothyroxine. Some of these patients keep checking every 15-20 days. So the ideal way is that you should check only at 6 to 8 weeks, right? So the ideal situation is an outpatient setting. Ideal time to recheck the TSH is at 6 to 8 weeks after changing the levothyroxine dose or after initiating levothyroxine. Now remember, the pituitary gland will reset after you give this patient levothyroxine, right? So when you start this patient on levothyroxine, the body will take a little time to get reset and the TSH will take a little time to get reset, right? So you should allow sufficient time for TSH to get adjusted to the new dose, right? And hence the optimal time, would be to recheck at 6 to 8 weeks rather than to keep checking at earlier intervals. So I've seen patients, check at 15 days and say, maro thyroid ajiba control, and goes back to the physician increases the dose. After a few weeks, the TSH becomes very low. And then, patient comes back saying that, maro thyroid ekdam ochu thai gyo. And then you have the doctor again, TSH bo ochu thai gyo, and doctor again adjusting the dose of levothyroxine. So I think it's a better idea instead of keep checking this, thyroid function every, 1 month, every 15 days. It's always a better idea to recheck at 6 to 8 weeks. That's a standard recommendation, allowing the body to, get adjusted to the new levothyroxine dose. So whenever you are changing the levothyroxine dose, always check recheck the TSH value at 1.5 to 2 months rather than checking it before that, because otherwise you'll lead to unnecessary dose adjustments which perhaps may not be required. Okay, a very important point which you need to understand, and very important and this could lead to serious problems, right? Some of these patients could have an hidden adrenal insufficiency, right? And this is in fact this paper which we had written and published it's a case report which we had published many years back. We had this young patient who actually had hypothyroidism, and the patient was started on levothyroxine, and patient ended up in emergency with adrenergic crisis. So what this patient actually had was an autoimmune polyendocrine syndrome, a Smith syndrome, which is where you have multiple endocrine disorders. This patient actually had adrenal insufficiency with hypothyroidism. So sometimes what happens is hypothyroidism masks the underlying adrenal insufficiency. And when you start this patient on levothyroxine, the underlying adrenal insufficiency often gets unmasked, right? So leading to what happens? So typically, again, to explain the situation better, so let's say patient has hypothyroidism and also has adrenal insufficiency. Now, you'd ask me, why would these two conditions coexist, right? This will coexist in many patients, in fact, because both tend to be autoimmune. Okay? So a lot of the times you have both the conditions pre-existing, right? So because of autoimmune nature, right? So sometimes you have a hypothyroid patient and adrenal insufficiency. Now, what are the symptoms of adrenal insufficiency? You have weight loss, right? And these are typical symptoms. And an overt hypothyroidism patient, or rather, on the other hand, would have weight gain and certain other clinical features. And what typically happens is when you have a patient with hypothyroidism, the metabolism often reduces. There is slowing of the metabolism. Because of slowing of metabolism, the patient's need for cortisol hormone also reduces, right? So the body requires less cortisol for its function. Now, what happens when you start this patient on levothyroxine? Suddenly, the body's metabolism becomes faster and more cortisol gets metabolized. And because more cortisol gets metabolized, the patient's adrenal insufficiency often gets unmasked. This is exactly what happened to this patient, right? So this patient, you can read this entire case report. It's available online freely. So what happened to this patient was the patient was having hypothyroidism and patient had adrenal insufficiency. So when this patient was started on thyroid supplements, there was an unmasking of the underlying adrenal insufficiency and the patient landed up with adrenergic crisis. Now, same thing happens, and again, very important point to really take care. Same thing can happen in pituitary. Sorry. Right? So in patient with pituitary dysfunction, and that's why it is very important to rule out central hypothyroidism. This is why I was stressing upon this point, right? So in pituitary disorder, what happens is you will often have patients with both adrenal as well as pituitary dysfunction, right? So you'll have cortisol, which is also low, and the thyroid function, which is also deranged. And this situation, what happens is if you start the patient on only with levothyroxine supplement, the adrenal insufficiency, the HP axis often gets unmasked, and because of that, the patient lands with adrenergic crisis. So again, in these situations also, you need to rule out adrenal insufficiency, and you need to treat both adrenal insufficiency as well as hypothyroidism together. In fact, you should start adrenal, the glucocorticoids before you start the patient on the levothyroxine. So this is something you should be careful. Of course, it cannot happen it will not happen in all patients. Up to 20% of patients with autoimmune hypothyroidism can have other associated autoimmune disorder like adrenal insufficiency, and this could lead to sometimes life-threatening, not myxedema coma specifically, but it could lead to some adrenergic crisis. So you should look at your patient carefully, especially overt hypothyroidism, and look for any subtle signs of adrenal insufficiency. And if you do find that suspicion, it's a good idea to first check the cortisol level also, or to rule out adrenal insufficiency before you start the patient on hypothyroidism treatment. So this is a very important nuance which you should try and understand. Okay, and then again, a very frequently asked question. I just added this because this is frequently asked by a lot of clinicians. Does checking the thyroid function require fasting? Right now, this is such an important question. Yet, not many studies have been done. Interestingly, the most comprehensive study done on this was actually done by Indians. Right in 2014, this is a paper published in Indian Journal of Endocrinology and Metabolism. Does fasting or postprandial state affect the thyroid function test? Right. Now, what was the conclusion from this study? And this study, I'll not read out the details, but what this study actually concluded is that timing of the sample or fasting or non-fasting state does impact the, the TSH value and the T3, T4 value. And hence, ideally, it's ideal to do a thyroid function test in fasting, right? This is ideal. Right? Now, what I'm saying is theoretical concern, right? In a practical sense, when you have a patient with overt hypothyroidism, the impact of fasting or non-fasting sample is small, right? So this small impact is generally tends to be small. In which situations should you really consider doing a fasting sample is in cases where there is a mild TSH elevation, right? Where you're looking at mild TSH elevation, where situations where you could have mild TSH elevation, especially in situations like pregnancy or infertility, right? So infertility. So this type of situations you should look at, perhaps looking at, doing a thyroid function in fasting rather than in a random situation. But when you're suspecting overt hypothyroidism, you don't need to worry about it. You can directly start send the thyroid function at any time of the day. The TSH is going to be very high, and in that big sea of high TSH, mild difference in TSH is really not going to make too much of a clinical difference, right? So this is something which you need to really understand. But this is a paper, again, like I said, in a lot of these patients, they actually took mild subclinical cases, and there was a reclassification in 75% of the patient based on fasting versus postprandial sample. So hence they suggested that it's a good ideally to do the test in fasting. But having said that, in overt hypothyroidism, it will not make a difference. In subclinical hypothyroidism, it can make a small difference, right? Okay. And what should you use for monitoring of a patient on follow-up? So when you're treating a patient with overt hypothyroidism, TSH often is alone enough for monitoring this patient. But if you have a patient with central hypothyroidism, you in fact do not do a TSH and you monitor this patient on free T4 values, right? So free T4 values is ideal for follow-up of these patients. So these are some important things. Another important practical point I'll tell you. So again, if you're trying to do a T4 or free T4 value, it is very important to check this before giving the medication for the day, right? So before the patient takes the medication for the day, the sample should be taken before the patient takes the medication, because otherwise what will happen is that sometimes we are taking a T4 medication and that itself gets detected in the sample in the blood, leading to again falsely elevated values, which again could lead to sometimes clinical correction, right? Another very important point, which I like to say, especially when we are talking about, overt hypothyroidism, there's often an overuse of NTTP antibody. Well, a lot of normal people in population can have NTTP positive, and remember, most of the patients with hypothyroidism that we see in clinical practice are probably autoimmune only, right? So really NTTPO does not serve too much of a purpose. There is absolutely no purpose of remeasuring NTTPO at frequent intervals, right? So that also is not something which is well established and does not, and overall NTTPO does not impact the patient management too much, right? So if again in interest of saving cost, perhaps NTTPO antibody need not be done. It's something, I think it's overrated in terms of its use, right? So they are and especially in overt well-established hypothyroidism, NTTPO has little role, right? And do not take this from me. This actually comes from Choosing Wisely Canada. This is a website by the Canadian Medical Association, where they looked at choosing tests wisely, and in this they had said that these recommendations come from them, not from me, right? So, but having said that, the point is that NTTPO antibody is often overused. It does solve a purpose. I'll talk about that when we discuss subclinical hypothyroidism, but does not have too much role in a lot of these cases. And again, thyroid ultrasound in routine thyroid patient also has little role. Unless you have a clinically visible goiter or a clinical visible thyroid nodule, you really do not need to do a thyroid ultrasound. A lot of the times, doing unnecessary thyroid ultrasound leads to, a lot of diagnosis of unnecessary thyroid nodules, which are then the patient has to undergo a lot of other tests, so which often leads to more problems. So in patients with hypothyroidism, overzealous use of ultrasound is often not clinically indicated. It could be, of course, you do it in selected patients where you are suspecting a thyroid nodule or a goiter, but in routine cases, you don't need to do a thyroid ultrasound, right? So this is something which you need to understand. So these are the nuances with regard to overt hypothyroidism management. Now we'll move to subclinical hypothyroidism, but before that, if you have any questions, would you like to ask any questions right now?
Just because semaglutide is being utilized more frequently, can you put some light on interaction between thyroid replacement and semaglutide?
Yes. So again, it's a great question. Again, what you need to understand is what studies have shown with semaglutide is that, in fact, semaglutide patients on semaglutide have an enhanced overall improvement in thyroid function, and the TSH, the thyroid requirement, often reduces. Now, we exactly do not know why. Is it because of the absorption of the medication which changes, or maybe because there is a reduction of lean body mass because of semaglutide, and because of that, or the volume of distribution, and because of that there could be issue. We don't know this for sure, but what clinically has been observed in studies and real world evidence studies of semaglutide, that the requirement, levothyroxine dose requirement often reduces in patients on semaglutide. Now, as far as the interaction is concerned and which medication to give first, that's an area of active debate. Current recommendations suggest, both from the manufacturer of semaglutide as well as general public recommendation, is that you give the patient a semaglutide first thing in the morning, and after 30 minutes you can give your thyroid medication. So we'll discuss this absorption of thyroid. It's a very, very important topic in the upcoming slides. But to answer this question, the answer is that you need to start the patient on semaglutide first, and after 30 minutes you give this patient levothyroxine, and after that you can ask the patient to take their, after again 30-40 minutes, ideally 1 hour, you should ask the patient to take their breakfast. Okay, so Yeah, so I think somebody has said, Archit has said it's important if patient has suspected metabolic encephalopathy. Yes, so NTTP antibody is useful in patients where you're suspecting a Hashimoto's encephalopathy. So yes, I agree to this point. So this is just one comment I read. So I'll discuss all the other questions later. Let's move on to the topic of subclinical hypothyroidism. Okay, so let's discuss the nuances of subclinical hypothyroidism management. So what is subclinical hypothyroidism? Like I already discussed, this is a situation where TSH is high. So you have TSH high with normal T3 and normal T4. So this is subclinical hypothyroidism. And these are the type of patients that you very often see in clinical practice. And the TSH value can go up to 10, in some cases up to 20 also, right? So up till 20, your T3, T4 will often be normal and TSH could be high, right? So this is subclinical hypothyroidism. How common is subclinical hypothyroidism? Well, if you see various studies in India, it ranges from somewhere between 6% to 20%, right? So there's about, on an average, about 10% of population has subclinical hypothyroidism. So it's a very, very common condition in clinical practice. So again, if you keep doing a lot of thyroid function tests like Thyrocare does, then you would find a lot of patients with subclinical hypothyroidism. Okay, so this, like I told you, the TSH often keeps increasing, right, to compensate for the reduction in T3, T4. So TSH always rises in primary hypothyroidism. TSH often rises first before the T3, T4 drops. So typically the TSH will rise, right, and then T3, T4 drops at a later date. So you can see somewhere over here, right, the T3, T4 levels are now dropping from here, right? So only when the TSH is typically more than, like I said, more than 20, in some cases more than 10, but between 10 to 20 also, but most cases more than 20 only, the T3, T4 starts dropping. Up till then, the TSH often compensates for the disease, right? Now, what are the consequences of subclinical hypothyroidism, right? So subclinical hypothyroidism has correlation with cardiovascular disease. It has correlation with heart failure. It can often lead to overt hypothyroidism in future with a risk of over 2 to 5% every year. It can be associated with depression and fatigue. It can be associated with fertility problems. Right, so NTTP has role in fertility related issues and in pregnancy planning, but like I said, we are not discussing those issues today, so we'll keep that aside, right? So in these situations, subclinical hypothyroidism has important clinical consequences. So let's take a case over here. So 53-year-old woman patient reports fatigue and mild depression, and she has no goiter on clinical examination. She comes with her triglyceride 190, LDL is 160, right? So this is an important nuance point here I'd like to discuss. And TSH is 8 and T3, T4 or normal or total T4 is normal. So how should she further be evaluated for her symptoms and how would you manage this patient? So this is a typical case of a subclinical hypothyroidism, right? So we'll come back to this case, right? What could be the potential differential diagnosis? So let's say this patient, right? This same patient, TSH is high, T3, T4 are normal. So what could be the potential differential diagnosis? So you could have subclinical hypothyroidism, which is obviously what we are discussing. Patient could have heterophile antibodies. We'll discuss, these are very important points. Patient could have macro TSH. Some patients could have adrenal insufficiency and present in similar way. Patient could have a transient, what is known as a transient subacute thyroiditis or a non-thyroidal illness. Or patient could have a central hypothyroidism, but in central hypothyroidism, like I said, contrary to this, in fact, T3, T4 will be low and TSH will be mildly elevated, right? So this is less likely. These are important differential diagnosis that we need to consider, or even this one, right? So this could be important differential diagnosis. So let's look at what is heterophile antibodies and what are HAMA, right? So HAMA is human mouse antibody, human anti-mouse antibody, right? So why this is important, right? So this is very important because we generally use ELISA for checking the TSH. Now this is a very interesting point. This is a very interesting point which you need to understand. So we use ELISA for checking the TSH. And in ELISA, remember, there is, so I don't know if I have a picture. I think I missed putting a very nice picture here. I forgot to put. But so what happens is, a lot of the time, the assay which you do is a sandwich assay, right? In ELISA. Okay, so you have the antibody. The TSH is the antigen in this case, and you have the second antibody, right, which is the indicator, right? So this is the typical sandwich assay, right? So when this entire sandwich is completed, right, you have positive, symbol, which positive indication which comes, right? So in a normal case, when the TSH is high, more the TSH, more the signal should come, right? But some people, what they have antibody against antibody. So they have antibody against these antibodies, which are there in the kit, right? In the testing kit, some human beings have antibody against the testing kit, right? So what happens in this situation? They don't have increased TSH, but they have antibodies against this testing kit. And because of that, this antibody binds with the testing kit, right? And hence gives a positive signal. So this is known as heterophile antibody, right? And one very specific type of heterophile antibody is HAMA, right? Human anti-mouse antibody. Now you will say why mouse is important. Mouse is important because these kits which are made by commercial kits which are available, they have antibody which are derived from mice, right? So they have often monoclonal or polyclonal antibodies derived from mice. And because the kit uses antibody from mice, if you have an antibody against mice's antibody, sometimes you can have false high value of TSH, right? This is a very, very important point, right? So this is something which is important to understand, and this is human anti-mouse antibody. It's a form of heterophile antibody. So what you can do in that situation, if you are suspecting that the patient possibly had a HAMA, as a HAMA, very simple thing, you can change the lab or you can change the kit, right? You can change the kits, especially if you have monoclonal kits. If you're using, you can use other type of monoclonal kit, right? Monoclonal kits are more expensive, right? So a lot of labs use polyclonal kits. But if you have monoclonal kit, you could have, it is derived from a single mice. So what you do, instead of you change the kit, and so that you have a different mice, right? So that that human being does not have antibody against that particular mice. So that could lead to sometimes normal result, right? So if you are suspecting HAMA, it is a good idea to either change the methodology or change the kit, right? And that situation, you could get a more. So a lot of times, patients come with saying that, મારું એક લેબમાં મેં કરાવ્યો તો 100 TSH આવ્યું, બીજી લેબમાં કરાવ્યો તો મારું normal TSH આવ્યું. એવી કે how can that happen, right? So that is because of HAMA. The second reason why this can happen is something called macro TSH, right? In this cases also, TSH values often are very high, more than 100, but T3, T4 are often normal. Patient is completely asymptomatic. So this happens because of an autoantibody called IgG antibody against TSH. So what happens is, body produces an autoantibody against TSH, and because of that, it clumps and has a long half-life. So TSH tends to produce a long half-life, and that's why you tend to have high TSH. This patient do not have any thyroid disorder, but they may have or may not have, but generally they do not have a thyroid disorder. But TSH values are often very high, and this can be easily removed by PEG precipitation. So if you talk to your lab, they can do a PEG precipitation, and this is similar to what you see in prolactin also. This is what you see, what is known as macroprolactin, right? So this is something known as macro TSH, and because of macro TSH, sometimes you can have very high TSH values, but patient is completely asymptomatic. Okay, so these are some of the nuances, right? So this is what we discussed, right? As far as differential diagnosis, you can have heterophile antibody, you could have macro TSH. Sometimes patients, like we already discussed, adrenal insufficiency. The patient could have an adrenal insufficiency, which sometimes, in adrenal insufficiency of the TSH, if patient does not have thyroid dysfunction, patient just has adrenal insufficiency, and TSH can be sometimes mildly elevated, and in that situation, again, this could be a potential differential diagnosis. And sometimes patient is going through, I will perhaps discuss in a future lecture, we'll discuss about subacute thyroiditis. So in subacute thyroiditis, the TSH often first reduces, then it becomes normal, and that it increases. And when it increases, often it comes back to normal. So sometimes, patient has a history of thyroiditis, and sometimes you check the TSH at this point of time, you find TSH to be elevated, but often after, if you wait for a few weeks, TSH comes down, right? So patient could be a part of subacute thyroiditis situation, right? And again, in that situation also, TSH can be elevated. Okay, so these are some of the differential diagnosis of a subclinical hypothyroidism. Now, how will you manage a case of subclinical hypothyroidism? What do you manage, right? So all you need to understand is this. So we have made this in our notes in endocrinology. You can take a screenshot of this if you want, right? We have looked at a lot of literature and finally come out with this algorithm for management of subclinical hypothyroidism. I think this is the most definitive algorithm taken from a lot of papers, guidelines, clinical recommendations, and so on, right? Now we are not discussing, like I said, fertility and pregnancy. We are not discussing. You need to see separate guidelines. So a patient comes with TSH which is high, right? Now, if TSH is more than 10, you should consider treating all patients, right? So you treat all patients with TSH more than 10 ideally. If the TSH is less than 5, you don't treat the patient, right? You just leave the patient alone. You can follow up the patient, right? Now, if the TSH is between 7 to 10, look at the age of the patient. If patient is young patient, less than 70, you should consider treating this patient. But if the patient is more than 70, right, treat only selected patients where you have some symptoms of hypothyroidism. In that cases, you could consider treating this patient. And then again, if the TSH is between 5 to 7, look at the age of the patient again. If age is more than 70, don't treat the patient, right? Remember, as the age advances, the TSH values often increase with age. Some of these patients actually have a normal TSH for their age, right? We don't have, unfortunately, have age specific cutoffs because we don't have, labs doing age specific cutoffs. But at 70, perhaps a TSH of 5.56 is often normal, right? So if you have age more than 70 years with TSH which is mildly elevated, you don't need to treat this patient. If it is less than 70, in that cases, you need to check antibody, you need to see the presence of goiter, you need to look for if the patient has CKD, high cardiovascular risk. We'll discuss all these points, right? And if you have any of these positive, this is where, TSH between 5 to 7 with age less than 70, this is where the role of NTTP antibody really comes. In these cases, you should treat this patient if you have any of these things positive. If not, then you can just leave the patient alone, right? So this is a broad guideline of understanding this, right? Now let's look at this from a more detailed perspective, right? Let's first take from the CV perspective, cardiovascular perspective. What it has been seen is that in patients with TSH more than 10, there is 1.89 hazards ratio risk, relative risk of cardiovascular mortality, which is significant, right? So if you have any patient with TSH, we already saw TSH more than 10, treat, because from a cardiovascular perspective, this holds true. So there is increased cardiovascular risk if you have TSH more than 10. And if the TSH is between 7 to 9.9, you have increased cardiovascular risk, right, which is significant if only in younger patients, right? So the cardiovascular risk, increased risk is only limited to younger patients. So in young patients, there is increased cardiovascular risk, but in older patients, right, the cardiovascular risk is not that significantly increased, right? So if you have TSH of 7 to 9, right, in young patients less than 70, you should consider treating from cardiovascular point alone. But from TSH between 4.5 to 6.9, there is no cardiovascular risk. There is no increased cardiovascular risk, and this is not statistically significant. And from a cardiovascular perspective, from a TSH between 5 to 7, you don't need to really treat this patient from cardiovascular perspective. In some other situations, you may treat. Okay, then again, treating patient, right, with subclinical hypothyroidism with these groups, right, where TSH is above 7, there is reduction of cardiovascular mortality. But in older patients, like I said, more than 70 years of age, the reduction of cardiovascular mortality may not be significant. Only in some patients there is significance which is attained, right? So in younger patients with subclinical hypothyroidism, there is cardiovascular mortality, cardiovascular benefit to be gained by treating this patient. But in older patients, this benefit is often not there, right? So this is a nuanced aspect of this, right? Now let's look at from the symptomatic perspective, right? So let's look at this case. 16-year-old girl comes with menorrhagia, and her gynecologist has referred her to endocrinologist. Her TSH is 8, right? All her other gynecological evaluation is normal. Should you start this patient on levothyroxine treatment, right? So this is where you come to this guide chart again, right? So look at this chart again, right? We rub some of these, right, in here, right? Okay. So if you look at this chart over here, now we are looking at this patient who is having TSH between 5 to 7. Her age is less than 70. She's a 16-year-old, right? Should you treat this patient, right? Now, this is where the issue of symptoms comes. So if the patient is symptomatic, right, or patient has increased cardiovascular risk, or the patient has a goiter, or patient has chronic kidney disease, or patient has antibody, NTTP or NTTG antibody, then you should treat this patient, right? So this patient clearly is symptomatic because she has menorrhagia, and perhaps in this situation, treatment would be beneficial, right? So in this case, what we have given provisional diagnosis of subclinical hypothyroidism with menorrhagia. Menorrhagia is an early manifestation of subclinical hypothyroidism. If you see this journal article here, and she was started on levothyroxine treatment, and her periods were eventually the menorrhagia reduced, right? So this is an important nuance point we have made, right? So hypothyroidism, remember, increases bleeding tendency, whereas hyperthyroidism increases clotting tendency, and hyperthyroidism, there is increased risk of thrombosis. So this is something you need to understand from an anesthesia perspective also. This is something you need to understand. Okay, then let's look at the third case. Patient comes to endocrinologist with goiter and TSH is 7.4. Should you treat this patient, right? Now, if you go back to the chart again, if you go back, I'll not keep going back to the chart, but if you see this chart again, right? If you see again, goiter is an indication for treatment, right? So this patient should be treated, right? Why this patient should be treated is because, okay, in fact, any patient with goiter with subclinical hypothyroidism, by giving levothyroxine, you can in fact reduce the size of the goiter, right? So the size of the goiter, there is statistically significant reduction in the volume of the goiter by treating this patient with subclinical hypothyroidism who has a goiter, right? So this becomes again an indication for treatment of this patient, right? So just to summarize, TSH more than 10, all patients you treat, but you looked at the other cases in young patients, TSH of this value between that, right? Especially more than 7, you should consider treatment because of cardiovascular perspective. But 5 to 7, right? Increased cardiovascular risk you treat. Your female reproductive abnormalities you treat. Symptoms like menorrhagia you treat. NTTP antibody or NTTG antibody you treat, right? And younger patients you consider treatments, right? So this is same again, the same guideline over here, right? So I hope this nuance is very clear, right? So this is the second point which I was trying to the issue of subclinical hypothyroidism, right? Again, we can take some questions if you have over here. Okay. So does anyone have any questions? Okay, so I think if there are no more questions, then let's move to the third point. And I think this is the most important part of this discussion today, and that is the point on the management of refractory hypothyroidism. Okay, so let's discuss this. Okay, so let's discuss refractory hypothyroidism. Okay, so let me first start with the case. So you have a young patient, 28-year-old patient who comes to, who is referred for uncontrolled hypothyroidism. Now she has history of recurrent first trimester abortion, which was attributed to her hypothyroidism. Her weight is 65. She's having TSH of more than 100. Her T3, T4 are normal, right? So you can say there could be macro TSH, right? So you could rule this macro TSH out. We already learned this, right, earlier. Her NTTPO is positive, right? Her levothyroxine dose is 175, which is 2.6 microgram per kg per day. Patient says that she is more or less compliant. Some days she misses the tablet. That is what she's saying, right? We'll have to take her word for that. She's taking oral iron, folic acid, B12 supplementation, right? And she's planning for pregnancy again. Okay, so is this what you call it as a refractory hypothyroidism? We'll see. So what is the definition of refractory hypothyroidism? So refractory hypothyroidism is defined as situation where TSH is more than 4.5 for 6 weeks after any dose increase, where levothyroxine dose requirement is more than 2 microgram per kg per day. So any patient requiring levothyroxine more than 2 microgram per kg per day is considered to be having refractory hypothyroidism. So this patient, you can see her levothyroxine requirement is 2.6 microgram, which fits her into the category of refractory hypothyroidism. Now, I'm sure all of you in your clinical practice would have seen such a patient having refractory hypothyroidism. So what are the steps in assessment of a patient with refractory hypothyroidism? Now, the most important thing in such patients is to check for the compliance. Compliance is the major problem. So you need to check compliance, right? A lot of the times, patients will say that, "Nahi, I'm taking the medicine, medicine low chu, I take medicine regular right? But often this is not the case. Second very important point is check the timing of the medication. We'll come to this point. Check for interfering medication. Very important point, right? Again, the list is long. We'll discuss this. If all these things, step 1 to 3 are ruled out, you need to check for levothyroxine absorption. And then finally, you need to, if you find there is absorption abnormality, you should need to look at cause of the malabsorption, right? So these are the steps of assessment of a patient with refractory hypothyroidism, right? Now, first thing is let's check compliance, right? This is very important, right? A lot of patients will tell you, like I said, that I am compliant, but it is not the case, right? They say 50% of the patient are non-compliant with levothyroxine treatment. There's no 100% compliance in 50% of the patient. In fact, a lot of these cases where they did levothyroxine absorption test, only 30% of patients had true malabsorption. Rest of the cases, there was no malabsorption. It was perhaps some other reason, maybe compliance was a factor. And studies have shown that out of 365 days, only patient typically takes medicine only on 275 on an average out of 365 days. So levothyroxine medication patient only takes 275 days on an average, right? This is a reality which you see with regards to clinical data as far as compliance is concerned. So compliance. This is often the most common reason for refractory hypothyroidism. How do you get a hint towards poor compliance? So a lot of the times, if you have a patient with elevated TSH with often normal T3 and T4, now again I said one differential diagnosis is macro TSH. So this is something you need to rule out as a differential diagnosis, but elevated TSH with normal T3 and T4 often sometimes points towards poor compliance or non-compliance, because what happens is that, like I said, TSH takes a little time for it to normalize, but T3, T4 often gets normalized faster. So because of that, what happens, if patient is going to come to the doctor, he or she knows that my thyroid function is going to be checked again. So because of that, just a few weeks before the patient visits the doctor, patient starts taking the medication again, right? Or becomes compliant with the medication. And in that situation, the T3, T4 often comes normal, but the TSH often comes elevated. So this is one very important hint towards poor compliance. Okay. Second very important and very often missed clinical issue is timing of the medication. Right now, this looks very simple, but the point is that this is often missed out in clinical practice. Now, food tends to have a very significant absorption on levothyroxine absorption, right? LT4 absorption. A lot of other medications also impact levothyroxine absorption. Ideally, levothyroxine should always be taken 1 hour before any food intake, right? This is very, very important. Or you can take 4 hours after any food intake. So levothyroxine medication has to be taken 1 hour before food intake or 4 hours after any food intake or any other medication, right? Again, if you're comparing with other medication, 4 hours of gap should be kept between levothyroxine and any other medicines that is to be taken, right? So again, let me reinforce this point, right? Your levothyroxine has to be taken 1 hour before food and 4 hours before other medications, especially the ones which tend to produce a absorption problem, right? Okay. So what are the various food and other items that can impede levothyroxine absorption, right? So this is a long list. I'll come to this points, right? But some very important, right? Proton pump inhibitors, very important, right? Calcium, right? Milk, coffee, okay? These are some common, situations, right? Papaya, right? These are all common situations which can absorb, which can impact the levothyroxine absorption. We'll come to these points, right? Now, how does levothyroxine get absorbed, right? So levothyroxine, when it's taken orally, it disintegrates and deaggregates. So first the tablet disintegrates, then it deaggregates, then it dissolves and forms aqueous solution in the stomach, right? So all these things happens at a gastric level, at the stomach level, and then it is absorbed from the small intestine. Now, very important, I think another take home message for today, the gastric, all this absorption occurs at low pH, right? So low pH is very important. Low pH is very important for disintegration and deaggregation and dissolution of levothyroxine tablet, right? If there is no low pH, then this process is often impacted, and because of that, the absorption from the small intestine is often impacted. Okay, so that's why acidic pH is very, very important for levothyroxine absorption, and any situation that reduces the acidic nature of the pH can impact the levothyroxine absorption. This is a very important take home message, right? A lot of food substances can impact levothyroxine absorption. Milk, coffee, papaya, soya, these are all common food substances which can impact levothyroxine absorption. A lot of the times, often you tell them that you tell that levothyroxine, आपको thyroid की tablet नाश्ते के 1 घंटे पहले लेनी है, but we forget to tell them that चाय और नाश्ते के 1 घंटे पहले लेनी है. So a lot of times I have seen patients take the levothyroxine tablet and have tea almost immediately 10-15 minutes after that. Because of that, the levothyroxine absorption can be impacted. Okay. Let's look at some of the medications that can impact levothyroxine absorption. So proton pump inhibitors, right? Why proton pump inhibitors? Because they increase the pH, right? So because of that, you could have impact on levothyroxine absorption. Iron tablets, calcium, both acetate and carbonate can impact absorption, especially carbonate. Carbonate impacts absorption because of the pH also, right? Various antacids like sucralfate, tricyclic antidepressant and beta blockers have a very unique mechanism. We'll discuss this. Fluoroquinolones can also impact levothyroxine absorption, and bile acid sequestrants like cholestyramine can impact levothyroxine absorption, right? Now, some of these drugs have a unique mechanism. So beta blocker and tricyclic antidepressant actually they use the same transporter which levothyroxine uses for absorption, and because of that, this could impact the levothyroxine absorption. And cholestyramine impacts the enterohepatic circulation of levothyroxine. In fact, this is the reason why cholestyramine in fact used as a off-label treatment for hyperthyroidism, right, in some of these patients, right? So that's why cholestyramine can in fact impact enterohepatic circulation. So this is something which is important, right? Okay, then there could be other drug-related factors which can impact levothyroxine, which can impact the dosage. Spurious medications are very, very common. Incorrect storage, right? This is very important. We'll discuss this point, right? Sometimes generic medication will discuss this point as well, and change of brands also impacts the levothyroxine absorption, right? Now, levothyroxine is one of the most commonly duplicated medicine, right? A lot of these medicines are spurious, right? In fact, the maximum spurious medication in the market is currently levothyroxine. You'll be surprised by that, right? So a lot of the times, spurious medications, of course, government is trying to, in fact, government came with QR code, and the first companies which actually incorporated QR code is the companies which produce levothyroxine, right? So spurious medications are very common, especially with levothyroxine. So again, you need to be you need to tell your patients that you need to buy the medication from reliable sources. Incorrect storage often impact levothyroxine absorption. So you're seeing levothyroxine with high temperature exposure, high humidity, light exposure, right? All these things can impact levothyroxine absorption and its ability. That's why you're seeing that levothyroxine tablets are also always in colored bottles or in plastic bottles, right? And often you have some sponge which are kept inside to or silicone which is kept inside to absorb the humidity, because high humidity can also lead to reduction of the effectiveness of the medication. Okay, very, very important. And this recommendation does not come from me, but comes from US FDA. Comes from Endocrine Society. Endocrine Society has been very strong in saying that the bioequivalence of levothyroxine is not similar for various brands, and that's why they recommend that do not recommend use of generic levothyroxine dose, right? So there is a big no-no to use of generic levothyroxine. Do not use generic levothyroxine because it can completely impact the thyroid dosage and requirement. Now, to show you this, right? In fact, the levothyroxine excipients in levothyroxine tablets are different for different brands, right? In this, I have circled two important brands that are available in India, right? This one is Eltroxin and this one is Thyronorm, right? This is Synthyroid, which is similar to Thyronorm, which is available. You can clearly see how different the excipients are for this medication, right? In some of these, these various groups of brands, you can see there are a lot of differences in the type of, here you have povidone, which is used, but in, Eltroxin povidone is not used, right? So again, here you have some other excipients like lactose. Lactose is used in, Thyronorm, but lactose is not used in Eltroxin, right? So these are some of the challenges which there are differences, and because of this difference in excipients, the absorption of these medications often differs. So that's why it's very, very important to understand that changing of brand also leads to change in the levothyroxine dose requirement, right? So these are the things. Some of these patients can have, one more important thing, right? We talked about lactose here, right? Thyronorm is a brand we often use, right? A lot of these brands have used lactose, right? And it has been shown that patients who have lactose intolerance actually respond poorly to these drugs. So if you have a patient not responding to a lactose containing levothyroxine tablet, you can shift the patient to a non-lactose containing levothyroxine tablet, which can sometimes, improve the outcome, right? Okay, so levothyroxine absorption test. So when should you do this test? This test should be done only when you rule out all the other cases where levothyroxine absorption leads to them, right? Now, these are generally to be done by endocrinologists. So if you have a patient where you're suspecting levothyroxine absorption problem, you can send it to your endocrinologist who can do a levothyroxine absorption test. Now, interpretation of the test is that more than 60% of the absorption is considered to be, normal, right? More than 60% absorption is considered to be normal, but less than 40% is considered to be abnormal and likely to suggest malabsorption, right? So, levothyroxine malabsorption, what are the conditions that can lead to levothyroxine malabsorption? Very important conditions are these three, right? Celiac disease, H. pylori infection, and autoimmune gastritis. All these conditions can lead to levothyroxine malabsorption. Giardiasis, gastroparesis, small intestine bacterial overgrowth can also lead to levothyroxine malabsorption. So if you have any of these conditions, if your patient has any of these conditions, you need to rule it out. And in fact, some of these patients, you have an occult celiac disease which was not diagnosed earlier. We can actually diagnose with the fact that the patient is having levothyroxine malabsorption, right? So these are all conditions. These are, a group of how you should consider, testing for malabsorption. We'll not go into the detail. I'll tell you some important areas. Celiac disease is very, very important, right? In fact, patients with hypothyroidism are more likely to have celiac disease. Again, the autoimmune nature, right? Celiac disease is an autoimmune disease. Same way, Hashimoto's thyroiditis is an autoimmune disease. So because of that, since you have more autoimmunity, celiac disease tends to be more prevalent in patients with hypothyroidism. So how do you screen for celiac disease? You do IgA, NTTP, and serum IgA levels. Right? These are done for screening for celiac disease. And if you have these tests positive, you should consider sending the patient to a gastroenterologist for doing a D2 biopsy for that, right? So celiac disease is a very, very important condition you should rule out in your patients with refractory hypothyroidism. Again, very important cause is H. pylori infection, right? H. pylori infection. How does H. pylori infection impact levothyroxine absorption? Remember, H. pylori infection produces gastritis, right? And this gastritis can increase the pH of the stomach, right? So the acidic nature of the pH is gone, and because of the acidic nature of the pH is gone, the levothyroxine absorption is impacted, right? So it's very important to rule out H. pylori infection, and you should consider treating this patient for H. pylori infection. But the problem is patients tend to develop recurrent H. pylori infection, and because of recurrent H. pylori infection, they tend to develop pan-gastritis, which can lead to gastric atrophy, right? So these are some of the situations which can happen, and autoimmune gastritis also can again often coexist with hypothyroidism. So autoimmune gastritis also you need to rule out for patients with this type of situations. You can easily diagnose, we can diagnose autoimmune gastritis by measuring serum gastrin levels and anti-parietal cell antibody, right? So you have IgG, anti-parietal cell antibody, which you check for in patients with suspected autoimmune gastritis. And gastroparesis, again, can impact levothyroxine absorption, especially very important, diabetic gastroparesis, right? So if you have a patient with diabetic gastroparesis, it's an important cause of so if you have a patient with diabetes and hypothyroidism, diabetic gastroparesis can also impact the levothyroxine absorption. Okay, so how do you manage a case of refractory hypothyroidism? So initial steps, again, check for the compliance, check for the timing and food medication, check for drug interference, right? And then you look at the medication related factors, storage of the medication, spurious branch, etc. And then if all these factors are ruled out, then refer to your endocrinologist for reassessment in terms of all these situations, as well as for going for a levothyroxine absorption step, right? So what does the endocrinologist do? He would do a levothyroxine absorption test. If absorption is more than 60%, he'll go back to again initial steps, right? It's 30 to 60%. Again, look at some of the other steps again. And if not, consider screening for malabsorption test, and less than 30%, definitely think for levothyroxine malabsorption related test, right? So for malabsorption, it's always a good idea to start with celiac screening. Celiac is not uncommon in India. Please trust me. Do not rule out celiac disease. Do not underestimate celiac disease. It's not uncommon in India. If the celiac screening with IgA, NTTG is positive, right, refer to your gastroenterologist and suggest gluten-free diet. If it's negative, do a H. pylori eradication. Again, if you talk to gastroenterologists in India, they'll say testing for H. pylori is generally not recommended. You can directly start the patient on treatment. If H. pylori eradication solves the problem, right, then it's good. Otherwise, you can refer to a gastroenterologist for further testing, right? So these are the points, right? So this is about levothyroxine malabsorption, right? So let's summarize and some important take-home message, right, for today. I think that's end of my lecture. First is central versus primary hypothyroidism. I already discussed this, right? So you have T4, which is low, with TSH, which is either mildly elevated, normal, or low. Think of central hypothyroidism, right? Important point. Second important take-home message, which you must remember, is you can start the patient on full therapeutic dose, 1.6 to 1.7 microgram per kg, of course, except for in elderly patients, where you can consider starting with a lower dose, right? Subclinical hypothyroidism, we already discussed the protocol for management of this, right? And I told you which cases you should treat and we should not treat. And finally, we discussed about the the concept of refractory hypothyroidism, and we said the timing of the medication, the compliance of the patient, the interfering medications, all these things need to be first ruled out, and storage of the medication and so on need to be ruled out before you go on to